Hi everyone, I'm going to talk about tuberculosis of hip joint. Hi everyone, my name is Dr.Senthil, Narayanan, Senior Resident Author. So today we're going to talk about tuberculosis of hip joint. So first we'll see about hip joint anatomy. This is the pelvis, femoral head articulating with acetabulum. This is the femur, femoral head and intracapsular neck and extracapsular neck. Head neck is articulating the capsule. It has blood supply from the medial circumflex femoral artery, lateral circumflex femoral artery, artery to ligamentum cuvis, which is a branch of obturator artery. So what is Babcock's triangle? It is a relatively radiolucent triangular area seen in the subcapital region of the femoral neck on an anteroposterior radiograph of the hip. So this is the Babcock's triangle. It can give a shape of a triangle. This is a radiolucent area. So what is it? It's a watershed area between obturator artery and the femoral artery. So in this region, the trabecula, the bone is relatively weaker in this region because the trabecula are loosely arranged and surrounded by more radiodense normal bony trabecular fluids. Initial site of infection in tuberculosis of the joint is the first. Notice the Babcock's triangle. So as the lesion will be initially present. So trabecula is a primary tensile trabeculae, compressive trabeculae, and secondary tensile and compressive trabeculae. All those things. So this is the Babcock's triangle. So first introduction, TB is one most common TB is occurs only secondary to the spine. The most common is TB spine. In the bone involvement of TB spine is the most common. And the spine to hip ratio is 10:7. Osteoarticular TB is 1 to 3% of all TB cases, of which TB accounts for 15 to 20%. Primary focus, primary focus of the infection is usually in the hip joint. The organism Mycobacteria belonging to the family Mycobacteriae, the order Actinomycetes, and Mycobacterium tuberculosis complex, and Mycobacterium tuberculosis, most common human pathogen. So, coming to that, most commonly the osteoarticular TB occurs most commonly after lung infection. The tuberculosis is the latent death, and due to endogenous route, it comes to the bone infection. So it comes from the primary focus. So the organisms are Mycobacterium, Mycobacterium tuberculosis, and Mycobacterium tuberculosis complex. And Mycobacterium tuberculosis is the most common human pathogen. So pathogenesis and pathology, the primary focus is the active or quiescent apparent latent infection and comes from the lungs. It may be active infection or latent infection or quiescent infection. To the emergenous route, it's disseminated after 2 to 3 years, and it comes to the bone to have osteoarticular TB. Initial focus of infection will be in the lung. Via hematogenous spread, the infection spreads to the hip joint. So from the lung, the infection starts and through the heterogeneous route, it spreads to the hip joint. So the organism reaches joint space through either subsynovial vessels or lesions in the epiphyseal bones. Articular cartilage destruction begins peripherally. So the organism usually reaches to subsynovial vessels, lesions in the epiphyseal bones. Articular cartilage destruction begins usually in the peripheral areas, not in the central areas. So the common sites on the TB hip is initial focus may start in the acetabular roof is the one of the site. It's the most common in the acetabular roof. The second is the epiphysis or the femoral head, and the third one is metaphyseal region. The fourth one is greater trochanter, which is the least common. So the most common is acetabular roof. The second is the epiphysis or femoral head. The third is the metaphysis, and the fourth is the greater trochanter. So pathogenesis of the TB. So first there is a tubercle or granuloma formation. So that is initial stage in the initial stages of infection. Usually in this stage it is usually asymptomatic. 2 to 4 weeks after infection, there will be 2 host responses. So once the bacteria enters, it is surrounded, it is shielded by the neutrophils and it leads to granuloma formation. Bacteria is not killed. So after 2 to 3 weeks only, there are 2 host response in response to the initial infection. So there is a macrophage activated cell mediated immunity. The T cell mediated response is related to the activation of macrophages and thereby killing and digesting the tubercle bacilli. Tissue damaging response. So it's due to the various bacterial antigens. The body responds to various bacterial antigens. There is also some tissue damaging response. It destroys unactivated macrophages that contain multiple bacilli. So cold abscess is the collection of the fibronecrotic exudates or tissues, dead bacilli. So all those contains collection of products or liquefaction or reactive excretion. It contains serum, leukocytes, caseous material, bone debris, and TB bacilli. It may rupture and leads to ulcer or sinus formation. There's a cold abscess tract. So different regions of cold abscess, what happens with cervical spine, cold abscess, cervical spine, thoracic spine, lumbar spine. All these regions have a particular tract where they can drain, leading to sinus formation or pain. So cold abscess forms within the joint, inferior or weaker part of the capsule, and it is perforated. Cold abscess presents anywhere around the hip of femoral triangle. So medial, lateral, and posterior aspect of thigh, ischiorectal fossa, and also in the pelvis. So in cervical spine, the cold abscess may drain to the retropharyngeal space, retropharyngeal abscess, prevertebral abscess, and in the thoracic spine, the cold abscess may track to the mediastinum, and in the intercostal, along the intercostal nerves and presents anteriorly or to the axilla. The lumbar spine, the cold abscess will track along the iliopsoas muscle and gives to the psoas abscess. So in the hip joint, the cold abscess ruptures from the capsule. It forms a tract to the medial, lateral, and posterior aspect of the thigh, and also ischiorectal fossa and also the pelvis. So clinical features of TB is the commonest age group is the first 3 decades. So the limping is the earliest and commonest symptom, and patient will have an antalgic gait. Antalgic gait is when the patient has a pain, there is a reduced stand space of the gait to clear off the foot from the ground as early as possible. They have a reduced stand space. So the earliest symptom is limping. It's the most earliest and commonest symptom. Pain referred to the medial aspect of knee, maximally towards the end of the knee. So hip pain is usually referred to the knee pain because there is a posterior division of obturator nerve also supplies the hip joint and also supplies the knee joint. So there will be a deformity and fullness around the hip, and there is night cries usually causes sleep awakening. So what is night cries? When the night cries is when the muscles are all in the night time, the muscles are all relaxes. Muscle relaxation occurs on the joint. The deformed or inflamed joint moves against each other and will produce a severe pain. The patient will usually wake up from the night and will cry in pain. So that is called night cries. So these are the clinical features, that is limping, pain, deformity, fullness, and night rise. So clinical radiological classification of tuberculosis of the hip. So there are four stages. The first one is the initial stage of synovitis. The clinical findings in this stage is flexion, abduction, external rotation, apparent lengthening. So the radiological features are haziness of the articular margin and rarefaction. So in the synovitis stage, there is the clinical findings are flexion, abduction, external rotation. There is some effusion in the joint. So only in the hip joint will be the in the effusion can maximum accommodate the hip joint in the position of flexion, abduction, and external rotation. There is also some length, apparent lengthening is there. In radiology, there is some haziness of the articular margin and rarefaction. Early arthritis. The second stage is early arthritis. That is flexion, adduction, and internal rotation. Apparent shortening is there. So the radiological findings is rarefaction, osteopenia, bony erosions in the femoral head, acetabulum, or both. No reduction in the joint space. Advanced arthritis, the patient will have flexion, adduction, and internal rotation. And there will be a shortening. All of the above on destruction of articular surface and the reduction in the joint space. Advanced arthritis with subluxation and dislocation, that is unstable hip. There is a flexion, adduction, internal rotation with gross shortening. Gross destruction and the reduction of joint space, and it will produce a meandering acetabulum. So the four stages, that is synovitis stage, that is early arthritis stage, advanced arthritis stage, advanced arthritis with the subluxation or dislocation. So in the stage of synovitis, the position of the maximum joint capacity is flexion, abduction, and external rotation. There is the apparent lengthening is there. And differential diagnosis is traumatic synovitis, non-specific transient synovitis, low-grade pyogenic infection, Perthes disease, and skippy. Ultrasound is repeated every 2 to 3 weeks, and X-ray can see soft tissue swelling and rarefaction. Early arthritis stage, there is articular damage starts, there will be a severe muscle spasm, there will be flexion, adduction, and internal rotation. Apparent shortening will be present, restriction of movements in all directions. Appreciable muscle wasting will be there, and MRI will show synovial effusion, minimal areas of bone destruction, and osseous edema. The X-ray shows osteopenia, marginal bone erosions, and normal joint space. In advanced arthritis, there is a flexion, adduction, internal rotation due to severe muscle spasm, and there will be a true shortening. Severity of the symptoms, capsule further destroyed, thickened, and contracted. So true shortening occurs due to the destroyed articular margins, femoral lead and acetabular articular margins. There will be true shortening. The capsule is further destroyed, thickened, and contracted. The X-ray you can see there is a destruction of articular surface, and there is a reduction in joint space. So in advanced arthritis with subluxation or dislocation, with further destruction of acetabulum, the femoral head, capsule, ligaments, and the upper end of femur is displaced upwards and dorsally in a wandering, migrating acetabulum, leaving its lower part empty and broken. So pathological dislocation of the femoral head. Movements are grossly restricted. So acetabulum is entirely grossly, severely destroyed. Along with the femoral head, there is acetabulum is migrated dorsally, upwards and dorsally, called migrating acetabulum. So on the classification, the radiological appearance classification, Shanmuga in 1983 classified the radiological appearance as type 1 normal, type 2 traveling or wandering acetabulum, Type 3 is dislocating type. Type 4 is Perthes type. Type 5 is protrusio acetabular. Type 6 is atrophic. Type 7 is motor and festule. TDP, PAM. So type 1 is normal. Type 2 is traveling or wandering acetabulum. Type 3 is dislocating type. Type 4 is Perthes type. So type 5 is protrusio acetabular. Type 6 is atrophic. Type 7 is motor and festule. So this is the Shanmugam Sundaram's classification, and the type 1 is the normal, type 2 is traveling or migrating acetabulum, type 3 is dislocating hip, dislocatable hip. So type 4 is Perthes like hip, and type 5 is protrusio acetabuli, type 6 is atrophic, and type 7 is motor and festule appearance. So X-ray pelvis with both hip joints showing the Perthes type of appearance on the left side. Wandering acetabulum, not the empty lower acetabulum. So acetabulum is migrated proximally and dorsally. That is empty acetabulum is there. Perthes type and the wandering acetabulum. So this is the protrusio type and this is the atrophic type. So on evaluation, there is hematological evaluation includes ESR, relative, there will be relative ESR will be elevated, there will be a relative lymphocytosis. So bacteriological, AFP staining and culture sensitivity, serological, ELISA, serum IgG and IgM, histology, the HPA histology for tubercular bacilli can visualize under the slides. Molecular PCR using 16 srRNA and clinical radiological investigations include X-ray, CT scan, MRI, ultrasound. So different diagnosis in liquid culture media, bacterial culture, and the initial rapid diagnostics are RT-PCR. So gene expert RT-PCR. Synovial fluid aspiration is AFB positive in 10 to 20% of the cases, cultures positive in 50% of the cases. Aspiration of cold abscess for microbiology, synovial biopsy is more reliable, cultures positive in 80% of the cases, granulomatous inflammation in the histology. So this is a technique of hip joint aspiration. That's an anterior technique, lateral technique. So two approaches. So it's a medial approach and lateral approach. So in the this is the adductor longus muscle, this is the gracilis muscle, and the needle is inserted in this medial approach, needle is inserted through the adductor longus muscle. So bacteriological diagnosis include specimen stain for AFP and culture sensitivity, stains used for Zeal-Nielsen stain, Oramen origin, fluorescence. Media used for growth is Lowenstein-Jensen media. And conventional AFP culture sensitivity takes 4 weeks and requires live organism, long incubation period, low sensitivity in patients already in ATT, and newer rapid culture technologies. Culture medium is BACTEC culture. The BACTEC is a radiometric culture system and detects the microbac as early as 7 to 14 days. Conventional culture medium Lowenstein-Jensen medium takes 4 weeks, and it can BACTEC and radiological, it can detect mycobacteria in as early as 7 to 14 days. It is based on the release of radio-labeled CO2 from the growth of mycobacteria in the selective liquid media using C14 labeled substrate. So culture is the gold standard. CT guided FNSA useful and minimally invasive method of ascertaining if dislocations, if pathologies. Screening tests include tuberculin skin test, mantle test, interferon gamma release assay. Tuberculin skin test is the purified protein derivative of the tuberculin. It's the antigenic culture extract injected intradermally 0.1 ml into the volar and dorsal aspect of the forearm. The results are read after 48 to 72 hours. It is considered positive when there is more than 10 mm in duration. Purified protein derivative is they inject the purified protein derivative in the volar 0.5 ml intradermally into the volar or dorsal aspect of the forearm. So when there is more than 10 mm in duration after 48 to 72 hours, I think tuberculosis skin test is positive. It measures delayed hypersensitivity. So radiological is X-rays, ultrasound, CT scan, MRI, and the management is early diagnosis, effective chemotherapy, vital to save the joint. Depends upon the stage of clinical presentation. The treatment includes ATT, absolute bed rest, action, excision arthroplasty, arthrodesis, total hip arthroplasty. Traction prevents, corrects the deformity, rest to the part, relieves muscle spasm, maintains joint space, minimizes the development of migration of acetabulum, and bilateral traction if abduction deformity to stabilize the pelvis. After 4 to 6 months of treatment, ambulation with crutches or arthrosis, and ambulation first 12 weeks is non-weight bearing, second 12 weeks is partial weight bearing. Unprotected weight bearing for 18 to 24 months after the onset of treatment. So, ambulation first 12 weeks is non-weight bearing. So, the second 12 weeks is partial weight bearing. Unprotected weight bearing for 18 to 24 months after the onset of treatment. So, category, the type of patients, regimens, and duration. New cases, new sputum smear positive, seriously ill, sputum negative, seriously ill, sputum negative, and the regimens are 2 HREZT plus 4 HR. So, this is 3 months, 2 months, and 4 months. So, duration is 6 months. And retreatment cases, sputum positive relapse, sputum positive failure, and it is treatment is for 8 months. 2 HREZTS plus 2 HREZT plus 1 HREZT plus 5 HRE. So multi-drug resistant TB cases, itacobacter, cyclophosphamide, and kanamycin, and all those drugs are given for this patient. The duration of treatment is 24 to 27 months. So cyclosporine, kanamycin, ofloxacin, and all those drugs are given for these patients. So this is the dose of antitubercular drugs for adult and children. So the isoniazid dose is 5 mg per kg, and rifampicin dose is 10 mg per kg, pyrazimide is 15 mg kg, streptomycin dose is and 15 mg per kg, ethambutol is 15 mg per kg. So side effects of anti-tuberculosis drugs: isoniazid causes hepatitis, peripheral neuropathy, pellagra-like syndrome, skin rashes. Rifampicin causes hepatitis, flu-like syndrome, skin rashes, respiratory hemolytic syndrome, orange discoloration of urine. Pyrazimide causes hepatitis, joint pains, and sometimes gout due to hyperuricemia. Ethambutol, there is ocular toxicity, red-green color blindness. Streptomycin causes vestibular damage leading to nystagmus, unsteadiness of gait, and reduces hearing. And ofloxacin causes GI symptoms, nausea, vomiting, anorexia. And kanamycin vestibular and auditory symptoms. And ethionamide causes GI symptoms, hepatotoxicity, impotency, and gynecomastia. So the important side effects of isoniazid is hepatitis, peripheral neuropathy. Rifampicin is hepatitis and orange discoloration of urine. Pyrazinamide is in orthopedics causes gouty arthritis, hepatitis, joint pain, hyperuricemia, and ethambutol is ocular toxicity. So, multi-drug resistant TB, the bacteriological diagnosis if the infecting organism is resistant to isoniazid, rifampicin, with or without resistance to other ATT. So, multi-drug resistance is bacterial organism resistant to isoniazid and rifampicin. So, extreme drug resistant TB, the bacteria strains resistant to fluoroquinolones and one of the injectables, that is kanamycin and amikacin. So the treatment synovitis stage, the treatment is chemotherapy, ATT, bed rest, traction, mobilization, exercises. Prognosis is very good. Surgical intervention usually is not required. And the early arthritis case, chemotherapy, traction, analgesics, non-weight bearing ROM X-ray started as permitted, synovectomy and joint debridement. Passive exercise pain spasm thus causes pain and spasm thus avoided. Prognosis in general is good. In advanced arthritis, all above and arthrolysis. Total, subtotal excision of the pathological contracted fibrous capsule and useful where limitation of movement is due to fibrous ankylosing. The aim is to achieve full useful ROM, posterior capsule undisturbed because it provides vital blood supply to the femoral head. Advanced arthritis with subluxation dislocation, conservative traction system, sound ankylosis in bad position, upper femoral corrective osteotomy, excision arthroplasty, arthrodesis, hip replacement. Advanced arthritis usual outcome is fibrous ankylosis. Once fibrous ankylosis is anticipated, accepted, limb is immobilized in hip spike off for 4 to 6 months. Ideal position for ankylosis, neutral position in between abduction and adduction. 5 to 10 degrees of external rotation and flexion depending upon the age. Children 10 degrees and adults 30 degrees. So the clinical classification, that is a synovitis stage and the clinical findings, radiological findings on the treatment and the early arthritis case, advanced arthritis, more than dislocation and later ankylosis. Excision arthroplasty is rarely being done nowadays. Gallstone excision plasty describes the excision of the femoral head, neck, and proximal part of the trochanter acetabular for chronic deep-seated infections of the hip joint, and be safely carried out in the healed or active disease after growth completion, and provide mobile, painless sleep with control of infection, correction of deformity. So the X-ray of right hip joint anteroposterior showing in active tubercular arthritis of the right hip. After Gallstone excision arthroplasty, the patient will have a mobile, painless, infection-free hip. So they have excised the neck and the head of the femur. Hip replacement in the THA in active infection is controversial due to the risk of reactivation. Most authors suggest total hip arthroplasty at least 5 to 10 years after the last evidence of active infection. Reactivation of infection in 10 to 30% of the cases, THA and healed TB is now accepted. Majority problem in the stage of advanced arthritis is sequelae when joint is unsalvageable. It's a total hip arthroplasty that's been done for the TB. Treatment in children synovitis in early arthritis, it is ATT, traction, bed rest, and supportive treatment. And in children with arthritis, it's traction. When there is a failure, there's open arthrotomy, thorough wound wash is given, joint synovectomy, and debridement of the dislocated joint. This is about TB hip, and thank you so much.